Welcome everyone. We're going to get started today. My name is Kari Williams, and I'm the User Engagement Manager at IPUMS. And I'm very, very excited to introduce our speaker. But before I do that, I'm going to share two announcements. First, please help us advertise our open funded pre-doctoral position in ISRD's training program within the population health branch. The start date for the position is January 2026, and we're beginning application review on November 24th. So please spread the word. And then the second, abstract submissions are now officially open for the 2026 Data Intensive Research Conference. That's an event that's hosted here. It's co-hosted by IPUMS and LCC. Every year there are flyers or little cards with details about that. This year's theme is novel data linkages and innovative life course research. Abstract submissions are open through January 30th, 2026. And I will sneak peek, there will even be a poster session at the conference that's sponsored by MPC. So if you heard LCC and you stopped listening to me, listen again and keep thinking about this. Those are the announcements. Now for today. Our next two seminar sessions feature faculty from North Carolina Agricultural and Technical State University. In summer 2024, the University of Minnesota and NCA&T established a research partnership and funded seed grants to develop collaborations. ISRD researchers and faculty from the Department of Population Health Management and Policy received one of these seed grants. David Van Riper, Dr. Jason Mose, and Dr. Celeste Butts-Jackson have started some collaborative work over the course of 2025 and are hoping to continue this work into the future. And so with that, we are very excited today to welcome Dr. Jason Mose to ISRD. Dr. Mose is the Director of Research Operations at the Alvin V. Blount Jr. Student Health Center at NCA&T, where he was previously an associate professor and the interim chair of the Division of Population Health Management and Policy. And he continues to teach and collaborate with colleagues in that department. Dr. Mose is also the executive director of the HBCU Health Equity Data Consortium, which is a strategic collaboration of 10 HBCU and MSI institutions across North Carolina that emphasize equitable approaches to community engagement, HBCU and MSI infrastructure development, reciprocal data literacy, advancements of health disparity research, and improvement of data equity for historically marginalized populations. Dr. Mose received his PhD from the University of North Carolina, Chapel Hill, and it is my great pleasure to present you with the mug that you can only get by presenting here.
Thank you so much. Thank you. And my research is going to, again, this is not a research product itself, but also I'm going to talk about the need for accurate measurement of quality, hospital performance. But also at the end, there's something that Kari mentioned that we are working with David. I want to ask if you are ready to jump in the fight and work with us, there's something you can contribute, right? So this is what we want to talk today, like the introduction and motivation, what motivated us to start looking at hospital performance measurement, and then talk about the challenges of causal inference, especially when it comes to hospital care measurements. Think about when we talk about hospital care, it can be things like readmissions, people who get medical errors because they were admitted, they were supposed to get amputated one leg, they amputated the wrong leg, right? Or sometimes they get overdose medications and all those kind of things. So all those things we know. For example, again, a few years ago, my dad was sick in the hospital. He had to go to ICU, and guess what? He got 4 hospital-acquired infections. And unfortunately, one of those infections killed him, right? So again, those are things that you should expect and avoid somebody getting infection. But is there measures that we can measure that say, hey, your hospital, you tend to have high infection rate than anybody else, right? Can we do something about that? Do we, do some preventative mechanisms? That's one of the things we say that, okay, if we have all this high mortality, can you link those to the hospital activities, right? That's a causal challenges I'm going to talk about briefly. And then we'll talk about evidence from advanced EHR adoptions. This is a work actually I did for my dissertation. In 2009, there is what they call ITEC Act. As part of the rescue package, some of you look young, might not be remembering what happened in 2008, right? But there was this, economic, downturn that the state, the federal government got this funding to incentivize hospitals and providers to install EHR systems. So I'm going to give evidence from that, once you adapt, is that going to help increase, your performance, right? And then we'll talk about designing new hospital service area and the referral regions and, the social determinants of health index. There's so many indexes out there, so we wanted to see okay, can we use one index that is actually related to the hospitals that we can use to measure hospital access or adjust for hospital access. And then we'll talk about the next steps and also conclusion. So again, Affordable Care Act, some places is hated, some places is loved, had a lot of changes to the healthcare system, right? So one of the changes it did is that instead of paying for what we used to call service, payment for service, you provide a service. We don't ask any question. You provided that patient came in and got knee surgery, you get paid $75,000. Now they say, hey, we want to know that patient, did they get better when they left the hospital? Or were they coming back again for the same issues to fix because maybe you didn't do well suturing, then now they got home in the bus and you come back, right? So now it started asking okay, under this value-based payment system, we not only give you money for service you provided, but also we want to follow through and say, hey, that patient should have not died during surgery. Let's look at, based on your characteristics as a hospital and your peers, they tend to, 25% of their patients, they tend to stay more than 3 days. Yours, it tends to stay 10 days, right? So to hold those people accountable. So that puts pressure on hospitals that whatever we are doing, then we want to be what? To provide quality care. But I gave an example of the admission reduction program. When it was, it was launched 2013, 2014, fiscal year, some hospitals that serve poor neighborhoods and all patients without insurance, looks like they were getting penalized at a higher rate than hospitals that serve affluent communities, right? So guess what? They discovered that actually did not account for the patient population characteristics. So they started adjusting for that. Also, the other thing is that if you are a patient, actually there's so many metrics from RIPFLOG to Center for Medicare and Medicaid. You can go in right now, put your zip code, and see the surrounding hospitals, the quality care they provide. For example, you want to go surgeries, you can see one hospital has a rating of 75, another hospital has a 95. You want to go to the 95 one, right? But sometimes those metrics are bundled together. It might not give you specific issue, right? If you want to have heart surgery, it might not give you an idea of who is doing well in heart surgery, right? So in other words, we need more metrics that can actually, if you are a patient, you can say, hey, this hospital, they can do well on this, but also these hospitals also tend to have more funding for patients who don't have insurance, right? And then also, again, for researchers, you might need to want to, test new ways of measuring healthcare performance and all that. But again, sometimes we don't know what we don't know, right? So even, again, I've seen some researchers from top universities do some research when I'm looking, actually one research we published with my friend and I was looking at the admissions, because some hospitals, like researchers from Harvard and the University of Washington in Missouri, they did this paper and we disagreed on the methodology, right? And then when we did the same data, because again, for example, there's about 3,500 hospitals, acute care hospitals, that are penalized under Medicaid, under that program. But then they only analyzed about 2,800 hospitals. We said, because maybe they dropped a lot of hospitals, that's why their stats were skewed. Guess what, when we did the analysis, we found it's true. We did an imputation so it don't drop in hospitals, right? So again, that's another thing for us to do this work. And then the last one is, there's a lot of indices that actually try to control for social determinants of health. There are so many of them. There's ADI, there's all this. Actually, when we did the evaluation this summer, there's about 7 that are widely used. But each one of them was designed for a specific thing, but not for hospital performance measurement. So again, let me mention quickly that some of the things that make the causal inference so difficult in hospitals, right? If you look at other countries, they have national healthcare systems that are actually unified across the country. Go to Canada, go to Britain, go to Germany, go to Japan. There's more kind of federal kind of like system that works, even the provinces or the regions, right? You come here, we have actually more than 50 different healthcare systems, right? If you think about, providers, for example, if you're a physician, your license is from the state, right? But the federal government also gives Medicare. Oh, no. There's also private insurance. Oh, there's Medicaid insurance. Oh, there's so many fragmentation that there's no unified system. So if you are trying to look at performance, hospital performance, you might have to account for insurance, not only just do you have insurance, but what kind of insurance do you have, right? So for example, if you have Medicaid insurance, in most states, they pay about 84 cents for every dollar hospital spends, right? You go to private insurance, they pay about $1.15 for every dollar you spend. So that's like, it's not only just that we are looking at whether you have insurance or not, but even that insurance can differ how much they pay. And actually, in North Carolina, we tried with my students to randomly call, providers and see if they take Medicaid patients. Every person we call, they say, no, we're not taking any Medicaid patients, right? So you might have Medicaid insurance, but guess what? You don't have access, right? So that's one example of how much fragmented the healthcare system is. And then if you look at the patient's contextual factors, hospital, by the way, if you look at, we try to map at this, it's not well defined, which hospital serves who, right? So sometimes, again, I don't know about here, but in neighborhoods I've lived, some patients, if you ask them, where do you want to go for care? They'll tell you like, no, take me to a further hospital that is far away because I know I'll get better care there because this hospital here, they will not provide care for me, right? So in other words, like, even if you want to see, hey, look at geographical access. That's not a well-defined measure where a patient can do what? Get care because they might overshoot some hospitals, go somewhere else because they believe that's where the people can treat them well, right? And then of course, there's overlap of that. If you look at some hospitals, they might have, for example, again, in Durham, North Carolina, we have about 3 or 4 hospitals, and most of them are owned by Duke Health System, right? If you look right now, Mayo Clinic just came up with an index where you can see the quality of care and patient-centered care that you can receive. One hospital has I think it was 91. They are owned by the same system, right? And another one has about 84. Why the difference? And yet they are owned by the same system. One treats certain patient demographics, another one treats different patient demographic, right? And again, you can imagine if you have funding, you have insurance and all that, you might get better at home after you get discharged because you're able to go fill the prescription. You're able to go follow up with your medical appointment. Someone else from the same hospital or the neighboring hospital does not have all those other things to follow through. And then also, if you look at the patient outcomes we are looking, there's this dimensional, right? It's not one-dimensional. So in other words, like those challenges make it almost really hard to have those causal inferences and say, hey, if you do this, we expect this result, right? And that's the challenge that we want to look at. So one of the major issue here is also this indigeneity, right? That there are different causes, and even teasing the cause of that indigeneity is a difficult one, right? Sometimes you can be like, okay, because we miss, for example, we want to see patients who do well after surgery, right? If, for example, we know for a fact that if you have family members at home, right? Let's say, for example, again, let me use that knee surgery again for the 3rd time, right? You get knee surgery, you get told that, you know what, we're going to give you a brace, but you have to walk at least once a day, right? That patient comes home, they don't have anybody, they live by themselves. Their neighborhood, actually you step outside the door, there's cars zooming by, right? That patient is less likely to do what? Go walking so they can get better quickly, right? And then yet another patient, they live with family, they live in a nice neighborhood, there's walkways. That family say, hey, grandma, let's walk outside. No, I don't, even where's my walker? Oh, here's your walker, let's do what? Walk. That patient walks every day because the grandchildren or the daughter or the son is helping them. Guess what? Now we want to assess the patient, that hospital, metric. We are using the same patient who had knee surgery, right? But one patient got better, another one did not. Guess what? That family component is a variable that we might not have even data for, right? So that can cause omitted variable bias. And then there is another issue of simultaneity, right? That if the surgery can lead to better outcomes, but also bad outcomes can lead to what? To that surgery, right? Like in other words, like it's both directional, right? So if, for example, you are, your issues, like your medical condition, you can also be alert to issues that you can do what? I'm getting out of breath when I walk the stairs. Maybe let me go to call my cardiologist to do what? To check me if I'm doing okay, right? So it's like you can be better after they check. But guess what? Because also you don't have all these other factors, that can also cause you to be sicker because you don't even know, right? So it's like it's both the direction, or it can cause what you are looking for, the outcome, but also can cause the causes, right? So that challenge is also there, that that can lead to bias estimate. And then measurement error, of course, we have a lot of folks here who collect data, right? We know that if you have measurement error, that can introduce to like faulty results, because if you have, for example, again, in healthcare, again, especially when we do a healthcare quality, healthcare financial measurement, there's a lot of data that is collected, but it's not accurate. Let's say, for example, you ask patients, how many times this week you fell down out of your bed, right? How many are going to say, I fell 6 times, right? So sometimes people might fall 6 times, but if they say even their children, again, I've had family members, if you ask them, did you fall down? No. Because they know if you tell them, they tell you they fell down, mom, dad, let's go do what? Go to the doctor. Maybe there's something wrong. They don't want to go to the doctor anyway, right? So people can report, under-report, over-report some stuff. Some stuff, again, we know that people don't want to report, especially those things that are going to be embarrassing for them, right? So even from that perspective, also like look at the hospital data when they report it. Sometimes they don't want to report the infections, how many patients died from the infections, because they know that think about it. If a hospital says a patient died due to medical error during surgery, it will be in the news, right? So nobody wants to report that. So in other words, like hospitals might not report, because all the data we collect from quality for healthcare quality is self-reported by the hospitals, right? So again, that is another maybe source of bias. So then when we look at limitation of hospital service areas and social determinants of health, so there's this metric that we've been using for years that was built by Dartmouth University in 1970s and 80s, right? So there's a lot of gaps on how they built. They built using only Medicare patients. And if we know Medicare, by the way, who qualified for Medicare? Who qualified for Medicare insurance? Yeah, that's the one that was started in Action 1973, right? The original was you have to be over 65, right? Of course, you have to be American citizen. There's nothing that allows you to get Medicare if you are not American citizen. And then also you must have contributed to Medicare at least for 15 quarters, right? So there's this again, and then of course they added if you have end-stage renal disease, and also if you are disabled, right? So those are the people called for Medicaid. If we will collect all the information we're going to use to build a model, then we're using those patients. What's the percentage of patients who are not included? A lot of people, right? Because even though Medicare covers millions of people, it doesn't cover half of the population, right? So now it's like this model was built using only Medicaid patients, and it was built 1970s and 80s. So now with all the changes that has happened, oh, by the way, there was a baby boom that was not captured in that Medicaid patient, right? We know from the last earlier 2000s to now, almost 10,000 people turn 65 every month, right? Every month or every day. I forget the exact matter. But again, that bulge of baby boomers was not accounted for this. And then look at hospitals, right? Hospitals have been built over the last 30 years, 40 years. Hospitals that was not existing, they're now existing, right? The number of hospitals that are built, even their own branches elsewhere, they were not covered at that time. And then, again, the other second thing is that they also use lack of representation of contemporary market. And that's what I'm mentioning, that the market, because they use service areas as a market, they are not the same thing. And then lastly, the methodological limitations, right? Again, it's not that methodology they use is not flexible, that you can update them quickly, so you can adapt to the new markets, also the new patient flows and all that. And also they only looked for admissions. They didn't care about what kind of service are you looking for. If you look for emergency services, it might be different than if you are looking for regular admission. If you came for special ed care, right? You might come, for example, again, I went to school in New York City. You see, like down in Manhattan, you can walk 15 miles, you have 15 hospitals, right? So and I was like, you know what, people can choose hospitals because I know like that hospital, they have good cardiologists. I'm going to go to that hospital. Oh, but it's just for regular checkup, maybe I have diabetes, my blood sugar was up, I'm going to emergency room, the closest to me, because The only thing I need to control is my blood sugar, right? So in other words, those choices are going to be different, but that methodology is not flexible to allow that variation on why you're going to the hospital. So let me give you an example that, you know what, some of these challenges can happen. So this again, this paper, again, as I mentioned, I wrote from my dissertation. I've sent it out twice. It was rejected because nobody wants to talk about EHR anymore. People have, you know, published hundreds of papers on EHR. But I thought like I repurposed this for this, you know, to show an example that actually sometimes based on the methodology used, you can have different results. So this paper, again, we use EHR sophistication. So there are hospitals that have those basic EHR systems, right? They don't care about this, so, you know, advanced, you know, what they call decision support and all those kind of things, right? And then we have different categories all the way to the most advanced, where you have all these bells and whistles that you can actually even do data archiving, and people can do analysis to do those to help you make decisions. And then also we looked the other variables, we looked for years of experience. The intuition here is that if you have had EHR, for example, if you go to a VA system, right? Actually, they started using the EHR system in the 1970s, right? They built, anybody remember the system they used? For years, they were building their own system until a few years ago when they had to move to a commercial system that costs about what, $2 billion? And it does delays. And anyway, that's another issue of government contracting, right? So, but they started, like, in other words, like if you're that hospital that has been using these systems for years, chances are that you might know how to get value out of those systems. As somebody who just got the system 2 years ago, you don't know how to even get value out of those systems. And then hospital characteristics, like we know, for example, rural hospitals, they are different than urban hospitals. Again, I've worked with some hospitals in North Carolina that even recruiting faculty, physicians is difficult because nobody wants to move to that rural area where there's no school for their children. They can't even have a nice restaurant to eat for them and all that. There is no airport there they can fly out of. So in other words, it's harder for those rural hospitals even to attract providers, right? So we want to control for those, like teaching hospitals, safety net hospitals, and all those other characteristics. And then we have community factors, using ADI, for example, area deprivation index, Sidene index, HHI. Anybody knows Havindo index? So anyway, these are index that measures the economic, market share you have of the community, right? So actually used by Justice Department, when you see when they have mergers and acquisition, they say, no, this merger cannot go forward because you want to have a consolidation of the market. It becomes almost a monopoly, right? So in other words, like, if you have this HHI that is huge, that means you control the market in the community that no another competitor is there, right? So we want to see if you are a competitor, then guess what? You don't care about what people think because where they're going to go. They're going to come to you anyway, right? But if you have that kind of high competitive market, then your healthcare quality and the financial performance is important because patients will go elsewhere, and you might not be able to succeed. And then, of course, when it comes to profitability, also financial metrics, we wanted to see the lagging of those indicators, right? So we know, for example, again, actually this paper was titled like Success to the Successful, the impact of EHR systems, right? So in other words, like if you are doing well financially, chances are that you have money to do what? To invest in systems that can help you do better next year, right? So again, if you look at this, whatever, so we had different methods, statistical methods, to try to see if there's a difference of outcomes, right? So for example, here, stage 1, again, that is the reference category here is the stage 0 that has no EHR system, right? And then we have stage 1, stage 2, and the stage 3 is the highest advanced system, right? So if you see here, we started with random. Actually, we had several models. Some of them, like almost the results were replicable, like, with random effect. So we kept one of that here. You can see there's no, among these 3 metrics here, like this EHR advanced, sophistication, you can see there's no one that is really significant, right? So, and then when you move to multi-level effects, again, this method was intuitive. Actually, we used it before because we expect that, a hospital is nested in a community, and that hospital is also nested in a referral region, right? So in other words, like the patients you get, because of your community factors, patients are also nested in the community, right? So if I live a certain neighborhood where I don't have access to food, I can't walk, I can't do all this, it's going to affect my outcomes. So in other words, like let's control for community in one level, and then the referral region and another level. So again, it's been used widely, especially in hospital care. The same thing, we were talking lunchtime earlier on about if you are a student in a school. So in also, we are looking for student outcomes who is graduating from high school to college. Guess what? We might look at the student, but the student is nested in what? In the school, right? So the school performance and the student performance jointly, we can see who is going to college, right? The same thing here. Patient issues can also affect, like it's nested in hospital and the hospital is nested in the region, right? All those nesting, we need to account for it. And you can see here also that we don't see any statistical significance of those. The third model is this linear extended linear regression that takes account into those indigeneity issues, right? Is there a reverse, causality? So once we do that, guess what? You can see the result, for example, the stage 1 hospital has 3.4 percentage points of profitability as compared to the hospital that do not have any EHR system. When it comes to stage 3, these are a more advanced system. You can see the profitability is about 7.4 more than the ones that do not have. And then when it comes to stage 3, which is more advanced, the highest advanced, it is 12.27 points as compared to the ones that is in the lowest level, right? So you can see again, the method here matters, right? So these other two, it appears they underestimate the effects of EHR system advancement as compared to the extended method. So the next model, what we did is that lag those financial indicators by 1 year, right? The idea is that, again, if you made a profit this year, because most hospitals, by the way, over 70% of hospitals are not for profit. You're not going to give dividends to your owners, right? The shareholders. You want to probably investing that money in what? In provision of health services, in improving the systems. So we wanted to predict, like, okay, if the results from 1 year ago, can they help predict the result of this year? And as you can see, the first stage 1 hospital, it moved from 3.4 points to more than 11 points over as compared to the hospitals, the lowest rank, right? And then when we did 2 years lagging, actually it went down, right? Showing us that, you know what, the last year's financial performance can be an indicator of how well you're going to do this year, all right? And then we look at, the hospital characteristics here, the safety net hospital. This looks at what they call, those hospitals that serve mostly patients who do not have either insurance or they come from low income, right? So in other words, like this hospital, these are the top quartile of those hospitals that serve indigent patients, or income-based or insurance-based. So we can see here in this, the multi-level model shows that, they actually do poorly as compared to non-safety net hospitals by 1.214, margin, right? And then when you come to this other model, guess what? There's no statistical significance, right? So in other words, like it says, these safety net hospitals almost perform as good as another hospital. There's no significant difference, right? And then you can see across all the way, there's no, in other words, if we were to go make a policy change, it's saying that, oh man, these hospitals are doing poorly because they don't have systems. Let's do something about it, right? And yet we found out actually, no, that's not true. And then you look at critical care access hospitals. These are hospitals with 25 beds or below, but serve a 15-mile radius. There's nobody else in that area, right? So mostly these are rural hospitals, or even if they are urban, then it means that, there's nobody who's providing care they provide in a mile, at least 50 radius, and they have less than 25 beds, right? Again, critical access. There is no another hospital that is providing that access. As you can see here, it overestimates again the impact, except when we come to this extended linear regression with 1 year lag. It shows then that actually they're doing well as compared to non-critical hospitals by 2.57 points of margin. Now, let me also define profit margin, right? Maybe I didn't define that earlier. So profit margin on average in this country, at least the last few years, the acute care hospitals average about 3.2, 3.8 to, like, now in 2023, they did so well. After the pandemic, they average about 4.5 to 5 points point margin. In other words, like, this money left after you paid all your expenses, this money left, you can do what? Invest back in your system, or you give shares of shareholders a dividend. So this is the money that actually shows. Remember, they talk about bottom line, right? So essentially, we're looking at how well are you doing financially, right? So in other words, like if you are on average, you have 3 points, 3.0 margin. When you have a hospital having 7.9, that's a lot of money, right? When you see hospitals having a 12.5 margin, actually they will be celebrating on the streets if they do that every year, right? So this is a big difference. You can see it's affecting them. And then you can see all the other hospitals down here, almost every metric, these two methods here, they overestimate or underestimate the effect of the EHR system. Any questions here? If the table is clear. All right. So the things that we're trying to do is again because again those data, as I mentioned, this table here, we suspect that because of that endogeneity. Remember we talked about omitted variable bias and all those kind of things that can lead to endogeneity. We suspect that because this method is addressing those, actually because even the variables we are including are not really the best indicators we can use. We are using some of them as proxies because we don't have better variables, right? We suspect that if we do better in the designation of hospital service area, and then these other metrics that we'll talk about in a minute, then maybe we can get closer to actually have that causational link, right? That if we do this, we expect this, and this hospital can be penalized or can be given a bonus based on the performance, actual true performance, not because our estimates are biased. So we want to include in this new hospital service area and also hospital referral region more updated methodologies, utilize data-driven and scalable methods. In other words, we want this, like, in other words, like, if things change, we want to scale that to accommodate the changing market areas. And then reflect current healthcare markets. As I mentioned again, the neighborhood where I live, some hospitals have been built actually, the last 10 years, they have built more than 10 hospitals in the same county, right? Because of population growth, but also because the population are dispersed from the center of the city, right? Again, even in the suburbs we used to live up to last year, literally there was a forest and farms, right? Right now, I went there earlier this year, there's homes being built everywhere, especially with all these companies from, IBM and Apple moving companies to North Carolina, right? So they're building hospitals, they're building homes because the population is growing, right? So in other words, like this methodology, we want to accommodate and capture those dynamics, market in dynamics. And also integrate spatial analysis. Again, I think I was talking to Andy earlier, we talked about how usually people used to use straight line to measure access to hospitals, right? If the hospital is closer to you, 15 miles, we assign you to that hospital. But nobody was considering, like, wait a minute, there's a value in between. And to drive to that hospital, it might take you 2 hours, right? Because you have to go around to get to the hospital. Now we use this, spatial analysis. We can say, hey, not only that we want to look at where they live, but also access, like, are there roads network? Are there buses? You might see, actually, one of my mentors worked in Indiana, in Indianapolis, in 1980s, 1990s. They had these patients who are coming over and over again to the hospital. They were wondering, and yet they missed their medical appointments, for follow-up for care after the discharge, right? So one guy asked, actually, he became a pioneer on EHR system. He asked the question, like, why is it that they don't go to primary care appointments, but yet they keep on coming to the hospital, right? So they said they overlaid all the data they knew. And when they were looking on the map, they found out actually that neighborhood where patients come to the hospital often more frequently, but they miss the appointment, there's no bus line that stops there, right? So they went to the city and asked him, can you add a bus line stop in this neighborhood? Once they added that, guess what? The admissions dropped and the medical appointments went up, right? So again, if you don't use these systems, like, you can map out geographically where they are, you might not be able to get good measurements. So, and then also consider patient demographics and needs. In other words, like, not all patients are equal, right? Some patients, last night we were talking about, like, some people go to certain neighborhoods and say, hey, we think you need food, a food store to give you fresh produce. And actually, I'm from Kenya. I went there last year. I was asking this clinic, I talked to the clinic, they said there are issues. They don't even have weighing scale for pediatric patients. They don't have a pharmacy. They don't have these things. I'm like, I'm just one person who is lowly paid by the state. I cannot afford to give you everything you need. So I started talking to the community members. It's the village I grew up in. I started talking to community members and they say, actually, the only thing we need is pharmacy. It's like now they have motorbikes even if pharma, whatever, I can go to the clinic, and once I get a prescription, I need to get what? My medication. Some of us are on long-term medication. I don't want to drive to town every time I need medication. Guess what? The needs of the community and what we think is different, right? So it's like, if we look at the community needs, what are those people needs, right? Then maybe when we build this service area, we can build it based on the demographics and community. Let me give you another quick example. I know I'm concerned, of time. My first hospital, I worked in New Jersey. We had a consultant come from Georgia, Atlanta. They wanted to build more OBGYN clinics, right? This was a major healthcare system in Jersey City. And they looked on the map and they said, can we build in this area and this area? And this consultant was paying, they were given a car, hotel and everything, and they were getting paid tens of thousands of dollars every 2 weeks, right? And my boss looked at me, I was intern, intern then, and she looked at me and said, like, you know what, can you tell him? I'm like, do you really want me to tell him? I was like, that neighborhood is called Jersey Heights. That neighborhood is retirees who live there. Why do you want to take OBGYN services? Because this person had no idea, right? And yet, that's exactly what we need to do. Like, look at the population demographics and then build that metric that is actually capturing the demographics, but also the needs for that demographic, right? You don't need to take OBGYN, anyway. and then also that kind of multi-level, as I mentioned, area. So when it comes to this index that we want to build, is looking at, we already collected data on these indices, and then we want to do, like, now next step is we have collected about 150 variables. We have seen how they are weighted and how they are planned out. So what we want to do is build an index that actually incorporates all these, but also aligned with hospital service area, right? So if you see some of these indices, they are built for county level or state level. That's not good enough if you are going to, for example, you look at Los Angeles County, right? It has millions of people. So it's not going to capture the nuances that are local to the hospital area, as opposed to hospitals that you can go 15 miles, as I mentioned, have 15 hospitals, right? So the next steps we want to do is like seek data access to some of these metrics we want to use. For example, we want to use all payer data set instead of only Medicare, right? So that all payer that can give us nuances of Medicaid, private insurance, Medicare, and all those kind of people. So we can, when we build this, actually we'll build based on where they seek care, which hospitals did they go to. The next thing is to refine our methodology again and to build this service area and the index. And then lastly, we want to validate it. So we make sure that when we tell people this is a good to measure patients with diabetes or whatever, we can actually, we have validated it is usable. And then lastly, what I want to say is that we want to use this resource to identify service areas, for better allocation of. Think about, for example, the state I come from, North Carolina. We have a community, a certificate of need. In other words, like if you want to build a hospital, you want to build a clinic, you want to build even an urgent care center, you have to go get a certificate of need. And also, you don't get allowed to build until there's a need in the community and the state has a board that approves you to have that, right? But without these kind of tools we are trying to build, they don't know which areas needs more support, which service areas we need, to build all those systems. And then again, if you care about healthcare disparities, right? Some of these things you can actually, if you build this, not only the service area, but also the index, you can pinpoint where actually there's disparities you can do something about. Again, this might need advocating, it might need nowadays I told a friend of mine, like, you know what, we can't just publish papers only academicians read, right? Let's use TikTok, let's use all these other tools. By the way, you need to, okay, anyway, but the point I'm trying to make is this. We can advocate even if we don't do anything about it. We don't just have to throw up our hand and say, it's too bad, too big, it's beyond me. No, we can do something, we can advocate, we can publish. Again, I told Carrie, like, the people I love to talk in conferences is politicians, right? I'm like, okay, especially those ones from my neighborhood, like North Carolina and all that. I'm like, I'm your, I'm from your constituency. You have 5 minutes to talk. I don't mind talking to them because, again, they need to know some of these issues. Health disparities it's not only about race, right? There's a lot of complexity that we can do what? Understand and help, those policymakers make changes. I'm going to stop here. And these are the references. again, they have the slides if you want to, and my contact information. We can communicate after this if you're interested. Any questions? Thank you. Thank you. Any questions? Yes.
Sorry, they've trained us well. So I am a data person, so I'm very interested to know about how your ability to estimate these models that you want is sort of shaped by data availability.
Yep. Yeah, that's a big issue. Honestly, like again, if we had more data access to patient level data, we can refine these models better because we can see like the hospital they were admitted to, on all those kind of things. But again, accessing even Medicare data, leave alone private insurance, right? It's expensive. The last time I checked, it was about $35,000 a year for a seat. And you cannot download, remember, like I buy a lot of data, for example, from American Hospital Association. They send me that data, they give me a use agreement for 3 years. After that, I can share with anybody I want, right? But this data, you go in, you can code and download the research, but you cannot even, export that data, right? So it's limited. Again, I talked to IBM, which owns the commercial, Medicare, yeah. And guess what? It was $65,000 for 1 year access. So for university like mine, we don't have that kind of money. And if you get a grant, you have to show that actually you have done this work before. So how am I going to do, this work before if I don't have access, right? So the challenge is that we try to do the best we can with the data we have. And if you know somebody with those access of data, I'll be talk to you. Maybe they can give us. Then we give them the question, they can help us work on those. For example, one of the things we want to use is those all payer whatever. We've been talking to other different universities to see if they can give us, they can give us ability to give them what we want. They can build it for us, so that we don't have to spend $65,000. Thank you. Another question? I see you have that question. You can say ask. Yes.
So what do you think selects health systems into adopting EHR if they didn't already have it? That the models that are addressing endogeneity are actually picking up. Like what do you think? Like where do you think the directionality is of those threats to validity?
So the first one I noticed is the funding issue, right? It's expensive to install those systems. The systems, again, I know some more systems have spent over $250 million to install the system. That's why I labeled the data like this, whatever work, success to the successful, right? Like the ones who tend to have money tend to also to install the systems. The ones who have less money tend to install them less. Even now, again, my follow-up, study wanted to look at the current, use of those data sets, right? Because we have all these variables, you can see how many people use decision support, how many people use this system. My intuition is that those ones who are strong, like, they had funding, they can do all those things, they can take people to training, they are more likely to use those systems as opposed to ones who do not have money. They might not have the trainings, they might not have even support staff to show them how to use those systems. So again, that's the first thing. But also the other thing I did not include that variable here is that we on this table here, I included, because we have the data that shows how much they were paid as incentive to install the system. Guess what? The likelihood of, if you had the system, you had incentive money, you're more likely to install the system, advanced system. Because again, but also there's this, big stick that the federal government had, right? They said they issued this funding from 2010. They said by 2014, if you do not have the system, you cannot bill Medicare. In other words, like some hospitals depend on Medicare payment. So hospitals had to rush through to make sure that they have the system. So that was another thing that they installed them. Actually, we know hospitals, they had stage 3, stage 1, meaningful use, stage 2, and stage 3. Some hospitals installed meaningful use stage 1, they met the requirement, but they did not meet the second stage requirement because they are like, we install it, I don't have money to continue doing this work. So it's like the predictor for most of the cases is the funding. of financial performance. Like in other words, like if you have more money, you can install the systems, you can use it. Actually, there are some papers also have shown that those ones with advanced systems, they also use them to essentially game the system, they get paid more. If you have done any work on hospital reimbursement, when you do coding, you can see, for example, heart failure condition has maybe 20 codes, right? So they can maximize the code that gives them the most money, right? It's the same code for heart failure, but maybe you add that the doctor spend 2 hours with these patients weekly on aftercare. Now you get paid more. So they tend to do better because they are doing all those things, but also they started ahead of time as compared to others. So that's where, again, simultaneity comes in, right? If you have money, we'll help you install the system. But once you install the system, it gives you more money. So in other words, like it's both ways. Yes.
Thank you so much for sharing your work. I think you mentioned, if I remember correctly, that this incentive to adopt these systems was part of Obamacare.
It was a high-tech act. It was passed during the Obama administration.
Okay.
But it was part of the rescue package of 2009.
Got it. Okay.
Yeah.
So I'm curious, what are the current political climates of this program? Is it something that the federal government is still incentivizing, or is this something that will be phased out? How would we interpret how this, the EHR
Yeah.
is moving forward?
So unfortunately, during the first Trump administration, there was this people who used to go to the, especially local physician practices to help them install the system. Actually, they discontinued funding those mechanisms early on. The same thing they did with, for example, right now we are going through the Obamacare enrollment, right? The last time they cut the weeks, they cut also the support for what they call navigators, right? So unfortunately, that's an unfortunate thing that with administrations. One administration comes in, cuts staff, the other one comes in, puts the money. So it's not predictable. If you are a hospital system that want to build these systems for the long term, you might be discouraged because you don't know what's going to come next time when they have changed administration. So right now, honestly, I don't know. I've not checked the recent, recently to see. I know most of the funding ended, I think, 2019, but I don't know if I will not be surprised if they never revive them in this administration. Yeah. But again, the other thing that the challenge is that we wanted to do a study to compare physician practice, especially those rural and urban, they don't have rich neighborhoods. Because they had those navigators, to see the impact of those navigators. I wrote to Medicare and Medicaid services. They said you have to go, because there were about 50 companies, not-for-profit organizations that were hired to be, to distribute those funds and support the navigators. They said you have to contact them directly. I contacted several of them. They're like, nope, we don't issue that data. And yet they publish papers. So one friend told me that, there's those, you can sue them to give you the data. They have had success in North Carolina. But I'm like, I don't have the time or the money. Yeah, any other question? But that's a good question.
Hello, thank you so much, Dr. Mose, for your presentation. I had a question about the integration of structural determinant of health data could you talk more about how that works and how that looks like?
Okay, so like some of these indices, for example, they look at geographical areas. It can be as granular as zip code level, right? And some of them go up to the states. So the goal is that if we can identify those drivers of healthcare, let me call it disparities, like the variation of healthcare quality index, outcomes and all those kind of things. If we notice, for example, these patients of this zip code, for example, they tend to have issues like they don't have access to medications, they don't have access to this, they don't have transportation, all those metrics, because again, as I mentioned, right now we have collected about 150 variables that these indices use, right? So we can narrow down and say, okay, these are the ones that actually can explain this variation in outcomes we see. Then what that can do several ways, right? You can integrate it. If you are a primary care, you can look and say, hey, this person comes from this zip code. I know they have access issues. Maybe there's a community organization that supports food pantry. Let me give them that. Have you had, nowadays, doctors prescribe nutrition? Literally, you can go in and they say, hey, we are going to prescribe you nutrition. This is like the same as medicine, right? So, and some of them, they can prescribe walking, right? Because in neighborhood, they know you can walk. They can't tell you that if they know that in your neighborhood, I live in New Jersey, where you step out of the house, there's cars, there's no even walking. If you want, you have to drive to a park. You don't have a car. So all those things you can take into consideration, even for providers helping their patients, right? The other thing we can do with it, as I mentioned, is policy issues. If, for example, right now in North Carolina, the state expanded Medicaid, but they are going to, again, there's a trigger law that says if the federal government does not pay the full cost of up to 90%, then they'll stop expansion. That is 600,000 people off the rolls of Medicaid, right? So if we can show that actually who is going to be impacted if they scale back that. The same thing with, with those subsidies about Affordable Care Act. Who's going to lose those subsidies? Their premium is going to skyrocket maybe 50%. Who's likely to drop out of that, insurance? And they show that and say, hey, this neighborhood is going to be impacted. These hospitals are going to be impacted. By the way, the rural hospitals did a good advocacy because they said that if you cut this much, most of us are going to go out of business, right? So that is the way you can show and maybe make advocacy more impactful by showing by data that these are neighborhoods who are going to be impacted and these are the people who are going to lose care, right? So there's multiple ways we can use that if we build it well, right? Any other question? Thank you for that question. Thank you again. Again, as I said, they have my contact information. I really, really appreciate you guys coming through. Again, I've not done face-to-face class this semester, so it feels like I was back in class. Thank you so much.